Welcome everyone, and thank you for joining us today. Today's session is focused on the upcoming OASIS-E2 version and the quality measure updates that are already impacting agencies this year. CMS has been laying the groundwork for these changes through quality measurement, risk adjustment, and value-based purchasing. Before we get started, let me introduce myself. My name is Terrence J. Finesse. I'm a CHAP certified home health professional operator, and I'm the product manager with Alora Healthcare. I've recently celebrated a 10-year milestone anniversary with Alora, but have been in the healthcare industry, primarily home health, for over 26 years. Just a reminder, feel free to drop questions throughout the presentation, and we'll address as many as we can related to this topic during the Q&A and if time allows. And if we don't get to your question, we'll be sure to follow up with a response via email. All right, let's start with what we'll be discussing during this presentation. By the end of this presentation, you should be able to know what was changed for the OASIS-E2 assessment and how these changes impact your agency. You'll understand the quality measure updates effective this calendar year and their impact on home health value-based purchasing and reimbursement. You'll be able to recognize how documentation accuracy, baseline scoring, and care coordination can influence your star ratings and financial performance. And finally, I will be giving a special preview of an upcoming AI feature that will help support caregivers and QA in improving or maintaining your star ratings. So let's start talking about the OASIS-E2 changes. The changes I will explain in OASIS-E2 may seem like minor updates, but it represents CMS's continuation to align home health with other post-acute care settings and with broader Medicare quality initiatives. These changes are designed to improve risk adjustment, strengthen health equity data, and make quality comparisons more accurate across different Medicare provider types. While the effective date is April 1st of 2026, just days away, understanding the intent behind the changes now allows you to adjust workflows, training, and quality oversight proactively. One of the themes you will see throughout OASIS-E2 is simplification and alignment. CMS is removing legacy items that no longer serve a strong analytic purpose and replacing them with standardized data elements used across other CMS programs. Another major theme is expanding data collection at the resumption of care time point. CMS views a resumption of care as the start of a new quality episode. Finally, there is a strong emphasis on access to care and patient barriers, which ties directly into quality measurement and risk adjustment. Transportation is an example of CMS refining how data is collected. The previous transportation item, A1250, is being removed from the start of care, resumption of care, and discharge assessments, and is replaced with A1255, a standardized version that aligns with other CMS assessment tools. And it is only assessed at the start of care and resumption of care, no longer at discharge. When comparing A1250 to A1255, the major difference is the simplification of the response. From a quality perspective, transportation barriers can influence outcomes, adherence, and utilization. So capturing this accurately at start of care and resumption of care is important. There are also some administrative cleanups in OASIS-E2. The MU69 gender item is being removed and replaced with A0810 for sex. While this does not change the amount of data collected, it aligns home health with how demographic data is captured across other Medicare programs. These types of changes may seem minor, but for CMS, so they matter for consistency, reporting, and downstream analytics. So far, these changes are so minor, your clinicians may not even notice. Hearing, vision, and language items are being added to the resumption of care time point. Historically, these items were only required on the start of care assessment. CMS is signaling that this approach is no longer sufficient. These elements are being used for risk adjustment, meaning CMS wants this information available at the beginning of each quality episode to calculate anticipated outcomes based on different case mix profiles. Make sure you educate your clinicians to fully reassess these items and not to respond to these from memory. If a patient returns from the hospital with new or worsened impairments, CMS expects that to be reflected in the resumption of care because it will affect the impact for risk adjustment in determining the ability for some outcomes to improve. Remember that a quality episode is from the start of care or resumption of care to a transfer or discharge. A patient can be admitted and recertified for multiple certification periods, but would only be considered one quality episode. Also, if a patient was transferred and resumed multiple times during their home health admission, they can have multiple quality episodes. The O0350 COVID-19 vaccination status is being removed in OASIS-E2. This item is collected during a transfer, death, or discharge assessment. During the public health emergency, this data was critical for monitoring risk and outcomes, and CMS has now determined that it is no longer necessary for ongoing quality measurement in home health. And this reflects a broader CMS trend of retiring data elements once they no longer meaningfully contribute to quality analysis. And I know we always love when CMS removes items from the OASIS assessment. Although it may not seem impactful at face value, this does help alleviate the burden from the clinician to investigate COVID-19 vaccinations. Also, I know I mentioned this earlier, but the transportation item was previously in the discharge assessment, but will be removed in E2. Whenever items are added or removed, skip logic must be updated. MU 102 skip logic now points to the replaced transportation item on a start of care and resumption of care assessment. And MU 1000 on a resumption of care skip logic now points to B0200 for hearing, which has been added to the resumption of care. While skip logic changes may feel technical, they're important for assessment accuracy and survey readiness. Incorrect skip logic can lead to incomplete assessments or data submission errors. Agencies should plan to review these changes closely within their EMR workflows and ensure clinicians understand where the assessment flow has changed. And of course, Alora will automatically implement the skip logic for you. The last OASIS-E2 change I wanted to mention is relation to mood D0150. For each mood item, CMS is allowing a dash selection for symptom frequency. And just like any other dash response throughout the OASIS, a dash indicates there is no information, and CMS expects dash use to be a rare occurrence. This guidance will be new in the OASIS-E2 guidance manual, but there was an errata released in December for the current OASIS-E1, which made this effective January 1st of this year. This affects the caregiver's response to J1800 and J1900 for falls since the last visit. A fall due to an overwhelming external force, and the example they provided was a patient pushing another patient, would now be considered a fall. Previously, falls due to overwhelming external forces were not considered falls. They have also added an exception to falls when clinicians intentionally challenge a patient's balance and is anticipating a loss of balance in relation to intercepted falls. If a patient's balance is being challenged during balance training by the therapist and it results in a major injury, it would be reported as both a fall and a major injury in J1800 for any falls since the start of care or resumption of care, and J1900 for the number of falls. This CMS correction was likely to go unnoticed. The OASIS-E2 final guidance manual was just released on February 26th of 2026, and I would highly recommend that agencies download this manual and review Appendix D, which highlights all the changes from OASIS-E1 to OASIS-E2, which includes all payer submission guidance as well, coding tip updates, and instructions. So now we're going to shift from OASIS structure to quality measures. Quality measure updates were effective this calendar year per the 2025 Home Health PPS final rule. And if you haven't been paying attention to CMS and Home Health Value-Based Purchasing, or HHVBP, these quality measures can affect your traditional Medicare revenue positively or negatively. If you don't understand why you're seeing an increase or decrease in expected home health revenue, it is important that you pay attention. The accuracy of your OASIS responses, the post-discharge planning, and patient satisfaction will have an impact on your revenue, and the impact won't be realized until it's too late. The payment year for your performance for the current year is a 2-year gap. The first performance year was in 2023, which would have impacted your revenue in 2025. Agencies could be experiencing a 5% increase or decrease in expected revenue per billing period. That means for a 30-day billing period of, let's say, $2,000, could see a maximum increase or decrease of $100 per billing period per patient. That is significant. Your quality measures this year, 2026, will affect your revenue for 2028. So it's really critical to have a strategy if you don't have one already. The quality measure changes do not currently have an impact on quality of patient care star ratings, but with home health value-based purchasing. Star ratings is consumer focused, and the quality measures used to determine star ratings are not the same as the quality measures used for home health value-based purchasing. They share data that consumers may be interested in knowing when comparing home health agencies and have been used as a marketing tool for potential referral sources. There are 3 categories to quality measures that drive home health value-based purchasing. These include OASIS-based measures, claims-based measures, and survey-based measures through HHCAPS. In calendar year 2026, they have added 3 new OASIS-based measures, 1 new claims-based measure, and 3 items removed from the survey-based measures. Along with these changes, the weights for each measure have also been updated and redistributed. This year, CMS introduced new functional outcome quality measures focused on improvement in bathing, upper body dressing, and lower body dressing. These measures are outcome-based and risk-adjusted. Keep in mind that these are not new OASIS questions, but OASIS questions that will be contributing to the OASIS-based measures that drive home health value-based purchasing. The other 3 measures that remain as outcome-based measures for HHVBP include improvement in dyspnea, improvement in management of oral meds, and the discharge function score, which was added on calendar year 2025. These changes have real operational implications. Clinicians will need education, not just on how to answer these questions, but on why accuracy matters. You'll want to make sure that EMR workflows support new ROC data collection. I'm referring to the risk adjustment items that had previously only existed in the start of care assessment. Quality assurance teams should monitor start of care and resumption of care documentation more closely, especially for items tied to risk adjustment and functional outcomes. And this is where agencies often see hidden performance issues. Preparation should have technically been started and ongoing. Agencies should update policies and training materials, including the OASIS-E2 guidance manual and audit documentation practices. This is also a good time to evaluate how consistently clinicians score functional items and whether interdisciplinary teams are aligned in how they assess patients. CMS recommends performing clinical audit visits quarterly, and the OASIS guidance manual provides some thorough guidance on how they should be conducted. Functional improvement measures depend heavily on accurate start of care and resumption of care scoring. They also complement another OASIS-based measure referred to as the discharge function score. The discharge function score is the percentage of home health quality episodes in which the observed discharge function score is equal to or greater than an expected discharge function score. If a patient is scored too high initially, there is little room to show improvement later. CMS recognizes that when patients are scored at or near independence at baseline, there may be limited opportunity to demonstrate measurable improvement, which affects functional outcome measures. Inconsistent scoring across clinicians or disciplines can also suppress improvement rates. If your patients are also receiving therapy, ensure that their evaluation and goals for functional improvement align with your OASIS responses. These measures directly affect HHVBP performance, which means they ultimately affect your revenue. OASIS-E2 supports fair measurement by strengthening risk adjustment. Hearing, vision, language, and transportation barriers all influence a patient's ability to improve. By capturing these factors more consistently, CMS can better account for challenges outside an agency's control. However, this only works if the data is accurate and collected at the correct time points. Medicare spending per beneficiary post-acute care is a new claims-based measure. Agencies do not document this measure directly, but they influence it significantly. It looks at all total Medicare spending during a home health payment episode and the 30 days following the episode relative to the national median. Rehospitalizations, emergency department visits, and downstream services all count. This measure reflects how well care transitions and ongoing management are handled. Prior to 2026, claims-based measures focused on utilization, hospitalizations during a home health episode, and post-acute care post-discharge. But now they're measuring cost and resource. Reducing Medicare spending per beneficiary risk requires more than good documentation. It requires strong care coordination, patient and caregiver education, and early identification of functional decline or clinical instability. Accurate OASIS data supports proper risk adjustment, but operational practices determine utilization outcomes. CMS expects that agencies that proactively manage transitions will perform better on this measure. HHCAPS has released a new questionnaire template that is effective April 1st of 2026, and they have reduced the number of questions from 34 down to 25. In 2025, there were 5 survey measure questions used for HHVBP. Several of the survey questions used to calculate this measure will be revised. As a result, they will no longer align with the measure specifications. 4 of the 7 survey items used to calculate the measure for specific care issues have been changed in the finalized survey, making it impossible to calculate the measure as currently specified. I would highly recommend that all agencies are familiar with the questions. You may want to consider performing internal surveys with your patients with questions that align with HHCAPS to gauge how they may respond during an actual HHCAPS survey. Although there are only 2 questions that affect home health value-based purchasing, more questions may be included in Care Compare. And the 2 questions that remain for HHVBP include the overall rating of the home health agency and the willingness to recommend the agency. CMS adjusted measure weights following a reduction in HHCAPS survey measures. The updated weighting places less emphasis on patient survey measures and greater emphasis on OASIS-based and claims-based measures. Weight was also redistributed within categories, increasing the importance of the MSPB claims-based measure and the new functional outcome measures. OASIS-based measures such as improvement in dyspnea and improvement in management of oral meds saw a 1 to 2% increase in weight from the previous year. Claims-based measures now carry greater influence due to their impact on Medicare expenditures. This means that claims-based measures have the same weight as OASIS-based measures. And so ensuring that the patient is stable at discharge and reinforcing education for safety to prevent or decrease hospitalization is critical. I also wanted to mention that although the all-payer OASIS submission has been required, the home health value-based purchasing model will continue to only report data for CMS programs, whether it be traditional Medicare, Medicaid, and Medicare and Medicaid managed care programs. CMS will notify providers when any decision is made regarding future use for quality or HHVBP reasons. I wanted to share that CMS does have a training module specifically covering the HHVBP changes based on the 2026 calendar year home health PPS final rule. It reviews the applicable measure set categories, added or removed quality measures, measure specifications, and weighting in greater detail, along with resources for home health agencies. Learners will engage in interactive exercises to support knowledge application. I've taken the course myself, and it doesn't take too long to complete. And I highly recommend it. All right, so let's do a practical strategy recap focused on protecting performance and maximizing revenue in this evolving environment. First, education should not be optional. Your clinicians must understand the OASIS-E2 changes, especially the importance of reassessing risk adjustment items at resumption of care. Hearing, vision, language, and transportation should never be copied forward from start of care without thoughtful reassessment. These items directly influence expected outcomes, and inaccurate responses can distort how your agency's performance is evaluated. Make sure they also understand the impact of home health value-based purchasing. explaining to clinicians that the accuracy of the responses will affect revenue. Ensure that your clinicians are consistently applying OASIS guidance. Appropriate scoring requires more than clinical judgment alone. It requires alignment with the CMS OASIS guidance manual and a structured supervisory or peer review process to promote consistency. The OASIS guidance manual does provide instruction on how you can perform supervisory or peer review for OASIS. Focus your best practice care principles towards optimal patient outcomes. Are patients that are at high risk for hospitalization provided enough education, tools, or resources to reduce the risk of hospitalization and post-acute care? Also, strengthen your QA process. Review OASIS assessments at start of care and resumption of care, not just at discharge. Do functional responses align with therapy evaluations in the plan of care? Is there a documented path forward towards improvement? If the assessment suggests potential improvement, your care plan should reflect it. They should also review that the care plan has been established appropriately to reduce hospitalization and post-acute care. How are the clinicians validating the education provided about their disease process? Did the patients and their caregivers actually absorb the information provided, and how is that documented? Finally, actively monitor your home health quality reporting data. Identify trends, measure performance against benchmarks, and prioritize improvement in areas that influence HHVBP adjustments and star ratings. This is where a strong QAPI program moves from, not just from compliance, but to financial strategy. As you can see, OASIS-E2 is not just a future compliance requirement. It is closely tied to how quality is measured today and how agencies are paid under value-based purchasing. And Alora already has a couple of features focused on improving process and outcome measures and identifying risk for hospitalization through our built-in scrubber, the OASIS Analyzer, and our OASIS comparison tools. But before we close, we also want to give you a preview of an upcoming AI-powered improvement designed to support HHVBP readiness and star rating performance in Alora. As most of our Alora partners know, Alora has already started diving into the world of AI and innovative solutions. This enhancement is focused on helping agencies connect documentation accuracy with quality outcomes more effectively. So, introducing the AI OASIS Star Rating Insights. The feature will provide quality measure feedback to clinicians in real time. This includes both process measures and outcome measures. They'll be able to identify when process measures or best practices are not being met, when there is potential for outcomes improvement on the start of care or resumption of care, and change in functional status from the initiating quality episode OASIS at recertification and discharge. In addition, there's also AI guidance available. So what will the clinicians see when they click on the AI guidance button? The clinician will be able to review the response in relation to the initiating quality episode OASIS where applicable. It will inform them of the impact on star ratings, potential contradictory findings based on their assessment, supported findings within their assessment, and additional AI clinical feedback. So this gives visibility into outcome trajectory. But wait, there's more. The validation page would summarize the quality measures and also include the ability to review the AI star rating insight. The quality measure summary page will also be available in QA mode as well, providing your QA team with the ability to monitor the quality measures without having to run any additional reports. I'm super excited about this one-of-a-kind feature, and I'm sure all the OASIS nerds and enthusiasts like myself are just as excited. This feature is currently active with our development team as we speak. All right, so here is the slide of some references, some sites that you can read up on. The more you know, the more you can prepare and strategize. Those asking about the OASIS-E2 manual, that link is at the very top. All right, so Alora customers, don't hesitate to reach out to our customer success or support team if you have any additional questions. And for those interested in joining the Alora family, I've included some contact information for our sales department. So thank you all for taking the time to join us today. We encourage you to review your current workflows, identify opportunities to strengthen documentation and quality oversight, and continue these conversations with your teams. We appreciate your attention and look forward to supporting you as these changes take effect. Thank you so much, everyone.